Today we are going to talk about a very important investigations which is sent by us in day-to-day practice. That is interpretation of liver function test, which is a very commonly ordered investigation in all clinical scenario. Liver function test, as we all know, the basis of this presentation is to know what are the basic tests which we order in liver function test, how the individual with abnormal LFT, how do we interpret that, and to recognize what are the common clinical conditions in which different parameters of LFT are deranged. So liver function and liver chemistries, they are not synonymous, because liver performs almost, you can say, 500 functions, more than 500 functions in our body. And just by looking at few clinical biochemical parameter, we cannot say the exact situation how the liver is functioning. But grossly, we come to know about few of them. So liver function is not synonymous with liver chemistry. What we are interpreting, that is mainly the liver chemistry. Look at the functions of liver. There are metabolic functions, which involves carbohydrate metabolism. We all know that glycolysis, glycogen synthesis, gluconeogenesis, HMP shunt, they all occur in liver. Coming to lipid metabolism, fatty acid synthesis, ketogenesis, cholesterol, a very important component in our body, the bile acid synthesis, even the hydroxylation of vitamin D to an active form, lipoprotein synthesis, all these occurs through liver. Protein metabolism, the synthesis of urea from ammonia, plasma protein, synthesis of coagulation factor, they all are through liver. The different hormone metabolism, their excretion of stress hormone, peptide hormone, that is all via liver. Coming to synthetic function, all the plasma, most of the plasma proteins, they are synthesized in liver. The clotting mechanism of our body is through liver, cholesterol, triacyl glycerol, and lipoproteins. They are manufactured in liver. Lot of excretory function in our body to excrete different types of toxins like bile acids, bile pigments, bile salt, they all are excreted through liver. The detoxification mechanism, like conversion of ammonia to urea, certain drugs or xenobiotics, they are excreted through liver. We all think that pancreas is the regulatory body for diabetes, but now we know that liver plays a very important role in glucose metabolism by glycogenolysis and gluconeogenesis. Storage function, we know that glycogen, different vitamins A, D, E, K, B12, and iron, they all are stored in liver. So it is very important to assess that what are the different functions which we assess, how do they help us? They help us to know the liver functioning, about the liver damage. The biliary system functioning can be assessed by LFTs. Many of the therapies we monitor by looking at LFTs, some drug monitoring, some clinical conditions monitoring. Extrahepatic, some of the dysfunctions like coagulation status of the patient, hemolytic part of hemolysis, that can be assessed by LFTs. A very important parameter is the nutritional status. About just by looking at the LFTs, we can tell about the nutritional status of the person and the body bone mass and bone turnover. So look, the information from LFT is not only about the liver, it is about biliary system, it's about the hemolytic system, bone and nutrition. So the lot of information we can get by looking at the blood test through LFTs. Coming to what are the functions assessed by LFTs, first is a hepatocellular function. You can say we have aminotransferases, which includes AST, that is aspirate aminotransferases, or ALT is alanine aminotransferases. Second comes the alkaline phosphatase, commonly known as ALP. Then comes the GGT, that is gamma glutamide transpeptidase. And another test is 5-nucleotidase. This is mainly used in research labs, not commonly available in normal LFT profile. The second is a synthetic function of liver, which can be assessed by looking at albumin and international normalization ratio, that is the INR. Then bilirubin metabolism can be assessed by looking at bilirubin, which is total, direct, and indirect. So these are the tests which we order when we order a LFT. Coming first to transaminases, that means AST and ALT. Their normal values varies in males and females. You can see the values are lower in females as compared to males. What are the functions that transaminases perform? They catalyze reaction between keto acids and amino acids. And ALT is more specific for liver disease. AST can rise in liver disease. And besides liver, there are many other organs like skeletal muscle, heart muscle, kidney, brain, and RBCs related disorders in which AST can rise. Age, BMI, metabolic factors, they all can affect ALT levels. And transaminases, I have already mentioned, they are used in specifically management of hepatitis B and drug-induced liver injury. Like if a patient is already on ATT, the monitoring the side effects of ATT is by looking at the transaminases. And in case of hepatitis B management, when we start antivirals, we look at the transaminases level to think of starting or monitoring the therapy. The transaminases, there are number of causes of transaminases increases. One is a hepatocellular injury. This can be because of alcohol, viral, drug toxicity, autoimmune vascular injury, fatty liver, congestive hepatitis. So a lot of gamut of causes are there to cause hepatocellular injury. And you see AST and ALT, they both rise in these cases. Second comes the biliary injury. This could be bile duct, that means bile duct problem, maybe due to stone or cholecystitis, cholangitis, or cholangiocarcinoma. Again, the level of AST and ALT, they both rise. There are certain extrahepatic conditions like rhabdomyolysis, that is a muscle disease, acute myocardial infarction, and hemolysis. These are the causes in which we have AST rise, but ALT is normal. A word about transaminases, that ALT is more than AST in most of the chronic hepatitis stage. But once cirrhosis develops, this ratio reverses, then the AST become more than ALT. Second important part in this is AST to ALT ratio. If this is more than 2, that shows that probably this injury is due to alcohol. And if this ratio exceeds more than 3, definitely this is going to be alcohol related. If this ratio AST-ALT is more than 5, that means there is disproportionate increase in AST level, that we should suspect extrahepatic sources of AST, that is, I have already mentioned in the previous slide, rhabdomyolysis, acute myocardial infarction, or other causes. Not only the ratio, when we see the range in which we get the report of transaminases, that in fact can lead to some suspicion in our mind that probably look for those causes. Like suppose the patient is coming with transaminases more than thousands, then what are the causes we should suspect? We suspect generally viral causes, viral hepatitis, ischemic hepatitis, drug toxicity, and paracetamol poisoning. This includes other drugs also. So whenever this is in thousands, we suspect viral, ischemic, or drug-induced injury. When the ALT, AST in alcoholic hepatitis or HELP syndrome, generally this is in the range of 300 to 400. And in cases of chronic hepatitis or steatohepatitis, generally the range of ALT, AST is in 200, or you can say it can reach till 300. Generally, this is the level of ALT, AST. So not only the ratio of ALT, AST, or the range in which we get the transaminases, we can suspect different causes accordingly. Then comes the second marker, that is alkaline phosphatase. What is alkaline phosphatase? This is a collection of isoenzymes which are present in our body. What are they? They form the family of zinc metalloproteinases, which catalyzes the hydrolysis of phosphate esters. And ALP we find in liver canaliculi, bone, WBCs, small intestine, placenta, and kidney. So look at the origin of alkaline phosphatase. We have so many areas. And how we can differentiate the origin of this? This is possible by isoenzyme fractionation, but which is not presently available in routine labs. Only in research purposes we can do this investigation. And ALP depends on age and gender. To help the interpretation of alkaline phosphatase, we have gamma GT. This basically transfers, this also catalyzes some of the chemical reactions in our body. It is, the origin is almost similar to alkaline phosphatase. This GGT has increases the hepatobiliary, basically increases mainly in hepatobiliary diseases. And the sensitivity and specificity is much more than alkaline phosphatase. GGT is not present in food. So if we have raised alkaline phosphatase and if we have confusion that what is the source of alkaline phosphatase in the body, rise in alkaline phosphatase, then we can take help of gamma GT. If gamma GT is also raised, then probably the source of raised alkaline phosphatase is hepatic or hepatobiliary in origin. So you just look at this table. The alkaline phosphatase increases in biliary pathology, liver problem, high bone turnover or bone loss, bony metastasis, hyperthyroidism, parathyroidic defect, Paget's disease, and even in normal pregnant patients, some increase in alkaline phosphatase is seen because of this is synthesized by placenta. And the gamma GT, what are the conditions in which it is increased? Mainly in biliary pathology and hepatocellular diseases. Some increase can be seen in diabetes patients who are on drugs like phenytoin, barbiturate. Mildly increase can be seen in renal failure, pancreatic disorder, MI, and alcohol. These are the conditions in which alkaline mild increase in gamma GT is seen. So if a patient is having increase in gamma GT, probably we think of that this is biliary in origin or hepatocellular in origin. So this table shows that if a patient is coming, it has raised alkaline phosphatase, raised gamma GT, probably the problem is with hepatobiliary system. If alkaline phosphatase is raised too much, the gamma GT is also raised. Look for biliary diseases, because generally in hepatic injury, the too much of alkaline phosphatase is not raised. So if ALP is raised to a bigger level and gamma GT is also raised, look for the biliary disease. If ALP is elevated and gamma GT is normal, look for bone disease. And if ALP is normal and gamma GT is only gamma GT is increased, then probably the cause of the problem is alcohol induced. So just by looking at the LFT, if a patient is having only raised gamma GT, think that probably the patient is consuming alcohol. We have interpreted raised alkaline phosphatase, but sometimes we get a report of low alkaline phosphatase also. And many a time this is interpreted as this is a lab error, but this is not so. If we get a low alkaline phosphatase level, look for hypothyroidism, pernicious anemia, some zinc deficiency, and specifically in case when a patient is having chronic liver disease and with low alkaline phosphatase, look for the Wilson's disease, because that could be one of the cause for low level of alkaline phosphatase in the presence of liver disease. Coming next to the synthetic function of liver, that is the albumin. The normal value of albumin is 3.5 to 5.5 grams per deciliter. This is produced only by liver and it has got a half-life of 3 weeks. So it forms almost, you can say, half of the total proteins in our body, and it is negatively charged, binds to calcium, sodium, potassium, some hormones, conjugated bilirubin, and some of the drugs. It is the main force which maintains the capillary oncotic pressure, and the level, if decrease, this serum level of albumin is decreased, that means definitely the duration of illness is more than 3 weeks, because we know that the half-life of albumin is 3 weeks. And any chronic illness can decrease the serum albumin level. Then we have another parameter which we can assess just by looking at the LFT, that is known as protein gap or gamma gap. This is defined as total serum protein minus serum albumin. So this normal value should be less than 4. If this value exceeds, what are the conditions which we suspect? Either we suspect sepsis, look for HIV, look for hepatitis C, and multiple myeloma can have increase in gamma gap. Autoimmune diseases, in this also the normal value of gamma gap increases. So looking at this, suspect number of conditions which we can confirm with further testing. Albumin in our body can decrease because of either there is decreased synthesis, which could be because of chronic liver disease or the patient is malnourished, or there can be increased loss, which could be because of nephrotic syndrome or protein losing enteropathy, a rare condition in which the albumin loss is there through the enterocyte, or there can be internal redistribution, like if there is increased capillary permeability and the seepage of albumin from the capillaries to the extracellular space is there. AG reversal. This is again a very important parameter which just by looking at the AG reversal, we can suspect that the early chronic liver disease is likely to be there, because this is a ratio which has got very high sensitivity and specificity. Coming to second synthetic function of liver, that is the INR. This is basically international normalization ratio. This is based on prothrombin time, which is dependent on the extrinsic clotting pathways in our body. This appears to be far more sensitive than albumin, especially when the injury is acute, because in acute injury, albumin may remain normal, but by looking at INR ratio, we can suspect that probably this is an acute injury to the liver. PT may be increased in severe liver disease. PT measurement may vary significantly between different labs. So to correct this, INR is a calculation which corrects the interlab variation of prothrombin time. So what we order PT INR. This is because the reading of INR is by a calculator corrects the interlab variation, which can vary from different methods used in different labs. What are the conditions in which INR is increased? This suggests there is decreased synthesis of clotting factors. So this can occur in chronic liver disease, acute liver failure, vitamin K deficiency, because all these clotting factors 2, 7, 9, 10, they are vitamin K dependent. So any condition in which vitamin K is reduced, like in malnutrition, fat malabsorption, use of broad spectrum antibiotics like which kills the gut microbiota, which were responsible for production of vitamin K. Patients who are on anticoagulant therapy like warfarin, comudin, dicumarol, they all increase they cause vitamin K deficiency in leading to increase in INR. Increased consumption, as we know that DIC is a condition in which the clotting factors are consumed. So this can lead to increase in INR, and even in hypothermia, a condition in which the body temperature decreases, so that can falsely give a high INR reading. Next comes the bilirubin physiology. We all know that how the RBCs are hemolyzed. Once the hemolysis of RBCs occurs, the hemoglobin is converted into, broken down into heme. Heme, through macrophages, is converted into biliverdin. Biliverdin is converted into unconjugated bilirubin, that is in the indirect bilirubin. Through glucuronic acid, this the conjugation of unconjugated bilirubin through glucuronic acid leads to conjugated bilirubin. So this bilirubin is excreted through biliary system. When it comes to urine, it forms urobilinogen, but when it comes to stool, it causes stercobilinogen. What happens? This conjugated bilirubin, a fraction of this bilirubin gets attached to albumin, which has got a half-life of 3 weeks. This is known as delta bilirubin. This is a concept which is very important sometimes clinically. Why? Because delta bilirubin is a fraction which causes delay in resolution of jaundice. Even if the patient is recovering from hepatitis or biliary obstruction is removed. The patients, they come that suppose a patient is having biliary stricture, we have put a biliary stent and the bilirubin is not coming down, then that can cause panic that why either the stent is not functioning or why it is not coming down. Then we can explain that this is delta bilirubin is the fraction which can still give the reading of raised bilirubin even if the obstruction has been removed. Bilirubin increased shows that either there is hepatocellular injury or biliary system pathology. So unconjugated serum bilirubin, we have seen where all we can have increase in unconjugated fraction. One is a hemolysis because there is more of RBCs are broken. So that causes more of unconjugated serum bil, which is high. To assess hemolysis, we can get other markers like decreased hepatoglobulin, increased retic count, increased LDH. So by looking at these co-parameters, we can say probably some sort of hemolysis is going on in the patient. Some genetic disorders, they can cause increase in serum bilirubin like Gilbert syndrome or Crigler-Najjar syndrome, in which indirect bilirubin remains high. Another important condition is known as Gilbert syndrome, a very common clinical condition we see in our day-to-day practice, which is seen in almost, you can say, 5% of population. What happens here? There is mild increase in indirect bilirubin and the patient is generally asymptomatic. and this bilirubin never goes beyond 6. And this is precipitated by fasting or any physiological stress on the body, like surgery or fever or any other stress. So what happens? The patient, they come with raised jaundice and they tell that this is a problem for last 5 years or 10 years, that my bilirubin is not coming down. And when you see the reports, only the indirect fraction of serum bilirubin is high every time, with normal transaminases, normal alkaline phosphatase, normal ultrasound, and other tests. So to convince them, we can get a test to confirm this. We can get an enzyme assay to confirm that this is Gilbert syndrome, and there is deficiency of that enzyme which can confirm the Gilbert syndrome. Then comes the conjugated serum bill. It is increase in biliary pathology, hepatocellular injury, and some genetic disorders like Dubin-Johnson syndrome, Rotor syndrome. So this bilirubin, if this is high in newborn, that is a problem, major problem, because this is very harmful for the newborn, especially when the bilirubin level goes beyond 20. This can cause neurological dysfunction. This is directly toxic to the neurons of basal ganglion and brain stem. It can cause increased sleepiness in the child, newborn, hypotonia, seizures, and death. And the patients who survive this episode, they develop kernicterus. This is a syndrome of permanent neurological sequelae in the survival. So a raised bilirubin in newborn is very, very important, because the level of bilirubin that guides the further therapy, phototherapy, or other exchange transfusion, which is the decision taken by neonatologists after the level of bilirubin what they see. So these we have seen the individual parameters. Now we will concentrate on what are the patterns in which, when we combine these parameters, what are the patterns in which we interpret the results. First is a hepatocellular injury, means the liver hepatocytes are damaged. In those cases, there will be disproportionate increase in transaminases as compared to alkaline phosphatase. Second is a cholestatic pattern, in which there will be disproportionate increase in alkaline phosphatase as compared to transaminases. Mixed pattern, in which both AST, ALT, and alkaline phosphatase, they are raised. Then comes the infiltrative pattern. Whenever there is infiltration inside the liver, that will increase the alkaline phosphatase and gamma GT, may increase some bilirubin, may increase some transaminases, but predominantly ALP and gamma GT will be high. Isolated hyperbilirubinemia, that means there is only increase in serum bilirubin with normal AST, ALT, and alkaline phosphatase. These are the 5 patterns which we can get when we order our LFT. So how do we interpret these patterns? We have a word called R ratio. What is R ratio? R ratio is basically ALT ALT measured, or ALT upper limit of normal, divided by ALP measured, or ALP upper limit of normal. This ratio, if we calculate, if this ratio is more than 5, that shows definitely this is hepatobiliary injury. If this ratio is 2 to 5, that shows a mixed pattern. And if this ratio is less than 2, it is a cholestatic injury. This is just a measurement. By looking at this ratio, we can calculate and we can think of what will be the probable site of injury. This is a table which again shows that if a patient is having hepatocellular injury, ALT, AST will be high, alkaline phosphatase may be normal or raised, bilirubin may be normal or raised, albumin may be normal or raised, or INR may be normal or raised. Then coming to cholestatic injury, in this AST, ALT may be normal or raised, ALP or GGT will be markedly raised, bilirubin may be raised or markedly raised, albumin may be normal till the time the injury is so severe that albumin decreases. INR again may be normal unless the problem is chronic and the injury is severe. Isolated hyperbil in which only bilirubin is raised, rest of the parameters are normal. Isolated synthetic dysfunction is the condition in which only albumin is low, PT, INR is more, rest of the parameters are normal. In case when the patient develops cirrhosis, ALT may be normal, AST may be normal, alkaline phosphatase may be normal, bilirubin may be normal, or once the patient decompensates, the bilirubin may be high. The only parameters looking at albumin, reversal of AG ratio, and raised INR. These are the parameters which we look to say that the patient has developed cirrhosis. This is very important to understand that in case of cirrhosis, there is almost you can see the maybe normalization of all these parameters, AST, ALT, alkaline phosphatase, and mildly raised bilirubin. Even the bilirubin may be normal in compensated cirrhotics. So we must, suppose an alcoholic comes and says that these enzymes are normal, I don't have any problem. Just you look at the albumin. If that is reduced and INR is raised, or there is AG reversal, then you can tell him that probably he is having liver disease and he should further get investigated. Coming to individually hepatocellular injury, which I have explained, AST, ALT will be high, alkaline phosphatase may be normal or high, bil may be normal or high, albumin may be normal or reduced, INR may be normal or reduced depending on the duration of illness. In this case, if we have AST, ALT ratio more than 2, that means probably the injury is due to alcohol. And if AST, ALT ratio is more than 5, that means probably the extrahepatic sources like rhabdomyolysis, that is the cause. And looking at the AST-ALT ratio more than 1,000, always suspect either this is viral, either this is viral or drug-induced or ischemic or some bud carry injury. So there are not many differential diagnoses. Looking at thousands of ALT, AST, suspect these causes. Coming to cholestatic injury, AST, ALT is increased, alkaline phosphatase is disproportionately increased, bilirubin may be normal or increased. Normally, albumin and INR are normal until the disease is very chronic and severe. So if ALP and gamma GT both are increased, look for biliary pathology like choledocholiathesis, cholangitis, pancreatic mass or cholangiocarcinoma, or intrahepatic problem like PBC or primary sclerosing cholangitis. So they should be suspected. And to confirm this, we can get an ultrasound, CT, MRCP, or endoscopic ultrasound to clear the problem. Increase alkaline phosphatase with normal GGT. That means extrahepatic problem like bone disease is there. So we need to look for bone scan or malignancy workup, TSH, calcium phosphate. So all these accessory workup is required just by looking increase ALP and normal gamma GT. Because in liver problem, both of them should be high. Unconjugated hyperbilirubinemia, maybe because of hemolysis, confirmed by increased LDH, decreased hepatoglobulin, positive Coombs test. Gilbert syndrome, I have mentioned, Kriegler-Nasser, they all can cause only conjugated hyperbil, unconjugated hyperbil, and conjugated hyperbilirubinemia, we can suspect hepatobiliary disease. To confirm that, we get an ultrasound done. We can have Rotor syndrome or Dubin-Johnson syndrome because of they generally can be diagnosed on the basis of liver biopsy, in which we see the pigment deposition on liver biopsy. Then end stage of any chronic hepatocellular or cholestatic injury, if a patient is coming with cirrhosis, so that is the final end result of any type of injury. In this, we can have normal or raised ALT/AST, alkaline phosphatase may be raised, bilirubin may be in compensated state. This may be normal to it can increase in decompensated state. But I have already mentioned albumin and INR. These are the two parameters and the AG ratio, which can confirm that the patient is going into chronic stage. So, end result of any chronic hepatocellular or cholestatic disease is cirrhosis. We must review the medication history of alcohol, viral pathology, autoimmune diseases, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency. We can get a CT done to rule out associated HCC, which can be confirmed by alpha-fetoprotein or PIVKA level. So these are the further investigation beside history. We can get a viral marker done, autoimmune marker done, workup for Wilson's, hemochromatosis. They all are the part of extended LFT. That is to know the etiology. Thank you.
This anemia is a very common disease, you can say, or you can say a symptom, or you can say a condition, which we see very often in our day-to-day practice as a laboratory person and as a clinician also. And many people contact me for the interpretation of various things, and whatever they are asking, I try to interpret that. So that way I also learn. Sometimes I learn from the mistake of others rather than committing ourselves and then learning. First, we will see certain cases. And this, all of you will agree with me, this pre-examination part is very important. Sample is collected in every healthcare organization, whether it is small hospital, big hospital, a standalone laboratory, and pre-examination errors amounts to about 80 to 85% errors. This 35-year-old female consulted her primary care physician for annual health checkup. And in addition to other investigations, the physician ordered CBC. Nurse was collecting sample and she found some difficulty in collecting a sample and she collected only 1 ml blood in 2 ml EDTA tube. Right, so only 1 ml blood was collected in 2 ml tube. Now look at these findings. Apparently everything is looking normal. Hemoglobin normal, TLC normal, platelets are also normal. And based on low MCV with normal hemoglobin, normal RBC count, how it was interpreted? Probably we are dealing with some hemoglobinopathy trait. When repeat CBC was performed in this condition, it was normal. And patient was investigated for iron deficiency as well as for hemoglobinopathy. Everything was normal and repeat CBC was also normal. What is the thing to be seen here? Ratio between hemoglobin and hematocrit is not maintained. It is 1:3. When only 1 ml blood was collected in 2 ml tube, excess EDTA caused shrinkage of red cells. Because of that, MCV came low, and hematocrit is a calculated parameter in our CBC counters. The hematocrit was also low. Had this been recognized by the laboratory person or clinician, those unnecessary costly investigations would have been avoided. So this pre-examination errors and correct interpretation is very important in addition to our examination area. Now see, this patient came for routine physical examination. He was enjoying good health and exercising regularly. There was no difficulty. And when this patient was investigated, again CBC, because today we are talking about anemia, so we are discussing CBC, hemoglobin low, TLC low, platelets low. And how it was interpreted? Probably this is a case of pancytopenia, incidental finding, and we have to go for bone marrow examination. But clinician thought when everything is normal, patient is apparently normal, they consulted laboratory. You just look at this again, and what happened? Technician noted a clot in the sample. Again, pre-examination error. So this pre-examination errors are very important and this shall be avoided. This 44-year-old man is hospitalized for pancreatitis. CBC sample was collected, and in this, hemoglobin was very high, 21.3. TLC was very high, 22.8. And again, how it was interpreted? They thought that we are dealing with some myeloproliferative disorder, maybe polycythemia vera, because hemoglobin is very high. But when the sample was examined carefully, sample was highly lipemic. Lipemia causes pseudoleukocytosis and pseudo increase in the hemoglobin. And when this patient was investigated, and then they cancelled the bone marrow, and the patient was investigated again after a few days, everything was normal. And high hemoglobin in a case of pancreatitis may be observed at the time when the patient is coming to hospital because of dehydration also. We have to see all these things. We have to keep all these things in mind rather than just jumping to the conclusion. And when triglyceride was examined in this case, it was 2251, highly lipemic sample and very high triglyceride level. Now, this patient presented with abdominal pain and diarrhea, diagnosed as viral gastroenteritis, and immediately IV fluids were started. And they collected blood also as sent to laboratory. And what were the findings? Low hemoglobin, low TLC, low platelets. Again, pancytopenia. There was no apparent cause of pancytopenia in this situation. And when they asked the nurse how you collected the sample, she collected the sample from the same arm where the patient was receiving IV fluids. So this is not the correct practice of collecting sample, so this shall be avoided. Because when a repeat CBC sample was collected next morning, it was normal. So that bone marrow biopsy was cancelled and the patient was discharged after recovering from the dehydration. Certain things we have to keep in mind in addition to just the interpretation of CBC. Whenever we are collecting blood, particularly in the hospital setup, in the nursing home setup, patient shall be identified correctly. Sometimes what happens, now patient has gone for the CT scan or MRI, and his or her attendant is using that bed. The person is lying there, and the person who is going to collect the sample, the person is collecting sample without identifying the patient. So patient shall be identified by name, and CR number also shall be checked. And when you are asking name, don't ask, are you Badri Prasad? Ask, what is your name? Let him say, what is the name of the patient? The patient shall be identified, and delta check is also very important. Whatever results you are getting, compare with the previous results. Because if there is significant change, so some reason should be there for that significant change. And you are collecting blood in that lavender top tube, EDTA tube, so it should be filled up to the correct volume as we discussed. Otherwise, some misinterpretation may occur. And also see at the time of receiving blood in the laboratory, there is no clot in the sample. And information on the test request form is matching with the information on the label. And if a patient is receiving IV fluids, blood shall be either collected from the different arm, and if you are collecting for some reason from the same arm, it should be distal to that IV cannula. To this, and when you're receiving sample in the laboratory, so this shall be checked, it is of appropriate volume. There is no significant lipemia. There is no hemolysis. Otherwise, repeat sample shall be collected. And very important, peripheral smear. What happens sometimes in hurry because there is request for urgent reporting. There is pressure on the laboratory. They are making smear hurriedly and without letting the smear to dry, they are staining. When this partially dried smear is stained, you will find target cells in some areas. If target cells are not uniformly distributed, these are because of the artifact. Otherwise, somebody may suspect some hemoglobinopathy because of these target cells. And if this roulet, generally you will find in multiple myeloma roulet formation in different direction. If roulet formation are in one direction, these are because of poor spread of the smear rather than pathological. Now see, this 27-year-old female, fever with altered mental status. Again, CBC was performed and what were the findings? Normal hemoglobin, slightly low platelet, high TLC, normal RBC count, MCV was normal, RDW slightly high. What they observed? They observed large number of fragmented red cells. And they thought these are schistocytes. And where you find these schistocytes? Schistocytes are observed in DIC and thrombotic thrombocytopenic purpura. DIC is a very alarming condition, but they ruled out DIC because in this case, D dimer was normal and PT and PTTK were also normal. So probably it was case of thrombotic thrombocytopenic purpura and they started plasma exchange immediately and patient responded. This patient from Thailand came and again CBC was performed. In this case, hemoglobin was normal, MCV normal, TLC normal, RDW normal. Everything was normal in this situation. What they observed? They observed large number of target cells only in one part of the slide. And because of this, they thought this is some hemoglobinopathy and this alpha thalassemia, hemoglobin E, these are common in this Thailand area. But when HB electrophoresis was performed, it was normal. And because target cells were distributed only part of the slide, probably these were artifact. So careful preparation of this peripheral smear and careful evaluation is very important. And it is very important how we are identifying schistocytes. And particularly here, I would like to mention one thing, because in our pediatric practice, we are very much bothered about band cells, whether significant bandemia is present or not. So how these band cells shall be identified? Neutrophil is considered as band cell if the thinnest portion is more than 1/3 of the thickest portion. Only then it is considered as band cell. And how we calculate the percentage of band cells? Number of band cells divided by total number of granulocytes into 100. It is not that number of band cells divided by WBCs. Number of band cells divided by total number of granulocytes. What I mean to say, band cells divided by neutrophils plus band cells. Now, this case, 30-year-old female, severe anemia. Hemoglobin was low, 6.6, MCV normal. And they ruled out dual deficiency because of this normal MCV. We have to remember one thing. Our counters, they are telling us average mean corpuscular volume. When peripheral smear was examined, there were macrocytes as well as microcytes. And when hematinics was started, this girl responded beautifully. This 2-year-old male with listlessness and pallor, and the boy is consuming milk every day, and clinician suspected anemia in this case and ordered a CBC. And what were the findings? Hemoglobin low, RBC high, MCV very low, and RDW high. What they thought, because MCV is very low, hemoglobin is low, RBC high, and RDW high, probably this is a case of hemoglobinopathy. Because RDW is high, so there is iron deficiency also associated. So they performed, but they didn't suspect hemoglobinopathy in this. Serum iron, percentage saturation, and ferritin was done, and these were suggestive iron deficiency, and they started iron supplementation. There was some response, but not very significant. Hemoglobin responded, but MCV remained low, RBC remained high. So what they would have done, they should have done hemoglobin HB electrophoresis also in this case to diagnose this hemoglobinopathy. And what they thought, this is resistant to oral iron therapy. Whenever we are performing CBC, wherever we are suspecting something, there are certain indices also, like Menzer index, MCV divided by RBC. If it is more than 14, it is suggestive iron deficiency. If it is less than 14, it is suggestive of some hemoglobinopathy trait. And sometimes what happens, when we perform CBC and we suspect and we find in HB electrophoresis a abnormal band in the region of HBS, that is in the region of sickle hemoglobin. If this sickle hemoglobin is less than 30%, we have to be very, very careful, because in sickle cell trait, sickle hemoglobin is more than 30%. If it is less than 30%, it is either iron deficiency associated or associated alpha thalassemia. This type of picture is very commonly observed in Odisha and Jamshedpur, etc., this Chhattisgarh area. This 33-year-old female presented with fatigue and weakness. They ordered CBC in this case, and they found low hemoglobin, low MCV, reticulocyte normal, RDW normal. Now, what is required in this situation? This reticulocyte count is apparently looking normal. But if you correct it for anemia, how it is corrected? Reticulocyte percentage into patient hemoglobin divided by normal hemoglobin. Generally, we divide by 15. So in that case, it will come out to be 0.4% low. So this is a case of non-regenerative anemia. Otherwise, they may feel it is some hemoglobinopathy trait, but this is a case of iron deficiency. And in newer CBC counters, there is one more parameter in the counter, reticulated hemoglobin. If reticulated hemoglobin is low, it is more indicative of iron deficiency, because we get this ferritin done. Ferritin is also a marker of inflammation. So you may find, and in India, iron deficiency is very commonly associated with anemia of chronic disease. There are a lot of cases of tuberculosis or other inflammatory diseases. So we are finding an iron deficiency, ferritin is coming high. So what is the solution? This reticulated hemoglobin is a very good parameter in this situation. See how you are identifying patients in the ward. You are identifying patients, you are asking from them their name. And sometimes people who are sending samples to laboratory, they think laboratory is analyzing only that particular sample. But laboratory is analyzing so many different samples from different wards, OT, CCU, or standalone laboratory from different hospitals and clinics, and patients are coming to them. So, how these samples are identified by the label. So, this label shall have appropriate information so that there is no confusion in identifying the specimen. Either it is barcoded, or even if you are labeling manually, what all information you will incorporate on that sample, that shall be uniform. See, after these cases, we will discuss briefly our approach. Lifespan of the RBCs is 120 days, 1% lost and replaced every day. And through the erythropoietic feedback loop, total red cell mass remains constant. And what is anemia? Simplest definition is insufficient red cell mass to adequately deliver oxygen to peripheral tissues. We are measuring either hemoglobin or hematocrit or RBC count. Hematocrit or PCV, these are same thing. When we perform manually, as we used to do in our college time, that is considered as PET cell volume. When we are multiplying MCV by RBC through our counter is providing us calculated parameter, that is called hematocrit, that is not measured parameter. And it is not always primary hematological problem. Some non-hematological conditions, chronic renal failure, hypothyroidism may cause anemia. Some therapeutic intervention, maybe surgery, antineoplastic drugs. Some other interventions may also cause decrease in the hemoglobin. When these findings are present, these are more suggestive of primary blood disease. Splenomegaly, lymphadenopathy, bleeding tendency, thrombosis, some non-specific symptoms like fever, malaise, weight loss, sweating. And here I would like to emphasize upon one point. Mild splenomegaly may be seen in up to 30% cases of megaloblastic anemia. If with severe anemia, and particularly, we have to be very careful when we are dealing with the case of pancytopenia. Most common cause of pancytopenia in our country is megaloblastic anemia. And if you are finding jaundice, unconjugated hyperbile, it is not always hemolytic anemia. In megaloblastic anemia, there is ineffective erythropoiesis, and we find the ineffective erythropoiesis, and because of that, we find unconjugated hyperbile. And in the same context, I would like to emphasize on another point. If we are finding megaloblastic anemia in a middle-aged person with normal nutrition status, we have to be very careful. We are not missing myelodysplastic syndrome or some occult other hematological malignancy. Because sometimes what we find overt, because of the rapid cell turnover, there is folate deficiency, and we are finding megaloblastic. When this megaloblastic anemia is treated and corrected, then we find that occult malignancy, hematological malignancy become overt. What is required? After careful clinical and drug history, thorough clinical examination, and after this, relevant laboratory investigation. And CBC with reticulocyte count and detailed smear examination is always the first investigation in anemia. Then we get clue what additional investigations are required. This is the lowest normal hemoglobin in various age groups. And what we have to see, Is anemia associated with other hematological abnormalities? If some other abnormalities are present, it may be leukemia, it may be aplastic anemia, myelodysplasia, myelofibrosis, leukoerythroblastic picture, or megaloblastic anemia. We will discuss these. And if there is no associated abnormality, what is the status of reticulocyte count? If reticulocyte count is increased, so we have to look for, that means bone marrow is responsive. Is there any evidence of hemolysis? Increased bilirubin or LDH or decrease in heptoglobin? If reticulocyte count is not increased, then it is non-regenerative anemia. We have to look for MCV. If MCV is high, so we have to evaluate for macrocytic anemia. Megaloblastic anemia is one reason, but alcoholism also may cause increase in the MCV. If MCV is normal, what are the possibilities? Renal disease or thyroid disease? If MCV is low, what are the possibilities of microcytic anemia, iron deficiency anemia, of chronic disease, hemoglobinopathy, certain, and sideroblastic anemia? And in this case, if there is no evidence of hemolysis, it may be because of some hemorrhage. If other hematological problems are abnormalities are there, like reduced platelet, decrease or increase WBC or abnormal WBC, as we discussed, it may be some leukemia or aplastic anemia. If there is pancytopenia, we have to look for causes of pancytopenia, and this evaluation of pancytopenia is very important. We will discuss this in the coming slides. And we have to see whether there is appropriate reticulocyte response or not. If retic is low, it may be because of decreased production. If retic is high, increased destruction or loss. Retic count may be spuriously elevated in anemia. It must be corrected. Corrected reticulocyte count is important. And additional correction may be for intense erythropoietin stimulation. Practical approaches look for absolute reticulocyte count. These automated analyzers these days, they are providing absolute reticulocyte count also. For hemolysis, as we discussed, what we do, we check unconjugated hyperbil, LDH, heptoglobin, and whether there is any hemoglobinuria or hemosideruria or not. If the retic is low, we have to see whether there is macrocyte, microcyte, or normocytes. As we discussed, these are the different causes of microcytosis. In this case, we ask for serum iron. If serum iron is low, generally, rather than going this way, we ask for serum iron, TIBC, percentage saturation, and serum ferritin. If iron is low and ferritin is also low, it is suggestive iron deficiency. If iron is low, ferritin is normal or high, it is suggestive anemia of chronic disease. If iron is normal or slightly high and ferritin is also a little higher, and we are finding some normality in the hemoglobin of HB electrophoresis, then we diagnose accordingly. If iron is high and ferritin is also high, it is sideroblastic anemia. We find sideroblasts in the bone marrow, and sideroblast is not observed in the routine stain. These are observed in iron stains. What happens in iron deficiency? Decreased iron, TIBC increased, decreased ferritin. We should not stop our investigation at this point only. Properly assess dietary status of the patient. Maybe normal. Ask for stool for occult blood or parasite. And whether the stool for occult blood is positive or negative, particularly in an aged patient, always evaluate GIT, upper GI endoscopy as well as lower GI endoscopy to rule out possibility of some bleeding ulcer. We have seen in many cases that we diagnosed bleeding malignant ulcer in the colon when we suspected that. Otherwise, if suppose a stool for occult blood is negative and serum iron is low, ferritin is low, then we think it is a case of iron deficiency and probably nutrition. But in aged patient, we have to be very careful. So this difference is more relevant generally for obstetricians in antenatal cases. Difference between iron deficiency anemia and thalassemia trait. In iron deficiency anemia, RBC count is decreased. In thalassemia trait, it is increased. RDW, red cell distribution width, increase in iron deficiency. Normal in thalassemia trait, reticulocyte count, decrease in iron deficiency, increase in thalassemia trait. Then this Menzer quotient, less than 14 in thalassemia trait, more than 14 in iron deficiency, and hemoglobin HbA2 less than 3.5 in iron deficiency and more than 3.5 in thalassemia trait. But when we evaluate, sometimes in borderline cases, it is better we are evaluating in context of MCV and RBC count. This diagnosis of iron deficiency is very important, particularly for pediatricians. Why? Although important for everyone. Iron plays a significant role in myelination and oligodendrocyte functioning, and they play a role in cholesterol and lipid biosynthesis. Because of this poor myelination and oligodendrocyte functioning in case of iron deficiency, you may find some behavioral abnormality and learning deficit. The child, they don't find any interest in playing, reduced physical activity, their language development is delayed, and poor scholastic achievement, and parents, they are scolding their children, you are not concentrating in studies, they are changing their school so frequently from one school to another school, this school is not good, another school is good, and iron deficiency is so common, particularly in slightly lower socioeconomic status because of poor eating habits, because of the parasitemia in their GIT. Increase MCV, maybe because of alcoholism, hypothyroidism. We find this in Plasmodium vivax malaria also, and megaloblastic anemia. Low retic with normal red cells, anemia of chronic disease. Acquired pure red cell aplasia, it is as a side effect of some drug, or it may be congenital pure red cell aplasia. Anemia of renal failure because of low erythropoietin production. And we have to understand this MCV is a mean value. It is not telling you variation in the population of red cells. When we are finding anemia, a careful evaluation of the blood smear is very important. In this, we find variation in the red cell size and shape. In iron deficiency, we find microcytes even when RBC indices are still normal. In folic acid deficiency, we find if macroovalocytes are present in addition to macrocytosis, then it is more suggestive of folic acid or B12 deficiency. Hypersegmented neutrophils. This is seen before this macroovalocytes and hypersegmented neutrophils, these are seen before the changes in MCV and hemoglobin. We find dual cell population in sideroblastic anemia, leukoerythroblastic picture that may shift to left, as well as nucleated RBCs in the blood we see in certain hematological condition, and other malignant conditions also. Some metastasis there, maybe breast malignancy metastasis, maybe thyroid metastasis in the bone marrow. We find agglutination in the cold agglutinin disease. These are the conditions where we need bone marrow to get the cause. If we are suspecting hypoplasia in the bone marrow or marrow infiltration or myelofibrosis, in myelofibrosis we find massive splenomegaly or sideroblastic anemia, megaloblastic anemia. Sometimes some people say nowadays B12 assay is available, folic acid estimation is available. What is the need of bone marrow? Why we go for this invasive procedure in case of this macrocytic anemia when these investigations are present? We can diagnose B12 deficiency and folate with these blood levels. That is okay. We also understand that. But the purpose of bone marrow is not to diagnose megaloblastic anemia. Purpose is to rule out occult hematological malignancy. A storage disease, bone marrow has definite role. And what is this pancytopenia? Low hemoglobin, low TLC, low platelet. All three are low. We go for bone marrow aspiration and biopsy. And it is a good practice if we go for both aspiration as well as biopsy. And when we are dealing with the case of pancytopenia, we have to remember one thing. Anemia is very common in India. And this anemia may be observed. This anemic patient may develop viral fever, enteric fever, and dengue fever. So then in viral fever, enteric fever, dengue fever, you will find low TLC, low platelet. And in anemic patient, hemoglobin is also low. You will find a picture of pancytopenia. So you have to be very careful. It is not a pancytopenia where you have some hematological problem. We may observe pancytopenia and megaloblastic anemia, aplastic anemia, PNH, leukemia, bone marrow infiltration. These are the different possibilities in pancytopenia. Important is we have to understand certain things. If we are finding microcytic anemia in aged male and iron profile is suggestive iron deficiency, don't jump to the conclusion this is a nutrition deficiency. It may be because of GI blood loss. We have to look for some cause in the GIT. Maybe simple, some hemorrhoids, or it may be some bleeding ulcer due to malignancy. And if we are finding macrocytic anemia with low folate level and bone marrow picture is suggestive of megaloblastic anemia, then don't stop here. After hematinics, again, look whether there is improvement or not. That way, we may diagnose some missed myelodysplastic syndrome or some occult malignancy which become overt after the folate correction. And most common cause of pancytopenia in India is megaloblastic anemia. Thank you.